Yeah, thank you, Worakan. It is my indeed great pleasure to moderate this particular second session in front of so many seniors, all part of the world, and everybody is telling good morning, good evening, good afternoon. So it actually justifies everything. It is my honor to introduce my friend, colleague from Indonesia. They have got a wonderful experience of large number of cases. Dr. Radityo Prakasho. He is from National Cardiovascular Center, Harapan Kita Hospital from Indonesia. And I found the recent publication in the International Journal of Cardiology. So may I request Dr. Radityo Prakasho to deliver a talk on where to go next with the transcatheter VSD closure using Konar MF occluder, the zero fluoroscopic way. So I welcome you.
Thank you, Dr. Nagewara. It's an honor to share here about our experience about zero fluoroscopy transcatheter VSD closure using MFO. Okay. First of all, I would like to thank Lifetech who support this presentation. As we know, the classical way of the percutaneous VSD closure is have a lot of publication using the MFO. And what's the point here? The interventional cardiologists experience highest amount of the radiation exposure concern of the brain cancer, let's say lens changes, thyroid disease, reproductive system, neurodegenerative disease. So also the exposure for the heart team as a scatter radiation has a serious environmental risk. So this is our experience about the zero fluoroscopy technique. Started in 1999, but is limited for the atrial septostomy. But for the defect closure, we started in 2018. Started with right heart catheterization and secondum AZ closure, and started from 2019. It started for the VSD, PDA, and sinus valve of fistula closure. So up to now, there's plenty of intervention using a zero fluoroscopy. The biggest part is still in the ASD closure. The VSD closure is until now we conducted 22 cases. The challenges is the visualization of the wire tip, the cardiac chamber, is quite difficult, but and it requires well-trained echocardiographer and interventional cardiologist, and that's operator dependent, but with zero risk of radiation exposure. This is the characteristic. We did several patients, and most of them still use the ADO2 because the Konar MFO just arrived in our hospital for only 1 month. So only 1 month we started the MFO, and we did 4 VSD closure with a zero fluoroscopy. So this is the how to do the zero fluoroscopy. We did with the transesophageal echo. So we assess from the long axis, it's the defect size, the distance from the aortic valves, the takeoff angle, and is there any RCC prolapse? Is there any AR or MSA? So the second one, we have to make sure also from the short axis view, when we measure, is there any, the distance to the tricuspid valve. And the last is the apical 5 chamber. So we can see also both orientation from the tricuspid and the aortic valve. So the pulse is the crossing the VSD, the high takeoff versus the low takeoff. So if the VSD has a low takeoff, you can use the Judkin right launcher to cross the VSD. But if in the high takeoff, when the angle is around approximately 90 degrees to the aortic plane, so you can use the internal mammary catheter. So this is the first case, 3 years old patient with 11 kilogram with PSD with 2 millimeters. That's 2.8 millimeters, and this distance is from the tricuspid valve is okay. And then we use the launcher Judge-Kin right 3.5, and then just when the catheter cross the aortic valve, so we can go directly into the VSD. The point is, if we do with the TE guided or zero fluoroscopy, you can see both plane of the catheter and also the VSD. So you can easily identify and easily cross the VSD. Once you cross the VSD, it's 90% finished. So just put the device and then deploy on the right side, and also and then the left side. After that, we can evaluate. Where can we evaluate? First from the long axis and the short axis, and also the last, the 5 chamber. Evaluated, is there any impingement of the tricuspid valve? Is there any disturbance on the aortic valve? You can see this is a little aortic regurgitation, but it comes from the cable. And then, is there any residual chance? After we release, you can see here, this is the picture from the axis and the 5 chamber. And then you can see also from the long axis, there's no AR. And the second case, 6 years old male, 17 kilograms, with the perimembranous VSD is 22.1 until 3.4 on the diameters. So we use this. We can connect. We connect at that time the distal disc instead of the proximal disc. And we use the MFO 6/4. And then what happened? After it deployed, it looks like normal with the trivial mild AR. But from the short axis, you can see there's a TR. But from the evaluation before, there's only trivial TR, but the TR is increasing. So I thought at that time the device is clamped to the secondary chordate. So we do the reposition, and then it's still there. So what next? So at that time, we changed the direction. So this part become the distal, and this part become the proximal. So we do the implantation with the same size. So this is the results. It looks like good. The TR is diminished, and then after release, there's no AR, and also the TR is diminished. So 2 weeks follow-up is a good position. And then this is the case 3. That's aortic VSD with a slight RCC prolapse. Yeah, this trivial AR. And then we try to put the device MFO, but the point is we do the proximal on the right? On the LV side is still under the aorta, and then we pull a little bit, and then it goes a better shape, and then we can see this still trivial AR because of the cable, So after that, we release the device, and there's no AR. So this is the post detachment. You can see the results. So all in all, the zero fluoroscopy VSD procedure is technically feasible with a little adaptation here and there until you get it as customized to the EcoView corner MFO. Thanks for the Dr. Nagewara who invented this device. We have waited here in our hospital for 10 years, but now we can use this. It's a very good, very soft. We can use the judge skin right catheter to low takeoff and into the mammary catheter for high takeoff. Communication between interventionist and echocardiography and the marshal as of us most important work as a team. Thank you very much.
Thank you very much. It's a great effort, and then you demonstrated without the fluoroscopy. It's not that easy to think, and it's very much technically demanding indeed. I appreciate and congratulate you. And probably we can take one or two questions. Maybe I would like to request Dr. Mario Calminati to give a comment if he is ready.
Well, I'm very spoiled in doing catheterization. It's very hard to me to get started by avoiding using fluoroscopy. I mean, I'm very reluctant in doing this. I think it can be possible for sure. It has been demonstrated very nicely, but I suspect that if I try to cross a VSD just by looking on echo, it will take much more time as compared to use a 1 minute or 2 minutes fluoro time. So I'm still not convinced that we should avoid completely fluoroscopy. Certainly, my opinion is that we can use both imaging technique to speed up the procedure and make it safer. So I'm still not convinced that we should avoid completely fluoroscopy. That's my own feeling. What do you think?
I think Dr. Ghee Tiong from Malaysia has got a question. Yeah, please go ahead.
Radityo, very interesting. Without fluoroscopy, have you done this in CalLab or you're doing in other place? Because there's a tendency for you to step on fluoro. Is there a time limit where you have tried for a certain duration of time before you step on the fluoroscopy? Or how many patients that you have actually step on the fluoroscopy? That's the question, yeah.
Okay, thank you, Ghee. So our experience, we plan to do the zero fluoroscopy for the VSD. We started on the less than 1 year, from August 2019 until now. And then we do 30 procedures, and 9 is converted to the fluoroscopy because of the procedural time more than 50 minutes. But all of them is less than 50 minutes. We did it in the cath lab, but until now it's getting much better. We started on earlier more convert to fluoroscopy, but now thanks God is fine.
Thank you very much. Are there any comments from Daniel or Jesus?
Yes, I had 2 patients with they were pregnant, and I avoided the fluoroscopy. So the problem is to get the heart because of the abdominal vessels. Sometimes it's difficult to get the heart. So this is my question. If you can use, for example, a balloon to get the heart, a wedge balloon, or not? Which is yes?
Yeah. We use the we use the retrograde. So we use from the suprasternal notch for guiding the catheter until the arc. After the catheter goes to ascending aorta, we can go to the the T again. So, but if we use the antegrade, we can use solely from the T.
Let me ask you a question to Radityo. Do you do the procedure in the cath lab or at the bedside?
And the cath lab, doctor. We still do the procedure in cath lab.
Why? If
Because the catheter is there. No. we used to do the ASD culture. Now is 100% zero fluoroscopy.
Okay, I think we'll move on to the next speaker. My friend Ghee Tiong from Malaysia, Sardang Hospital. Actually, he has got a very good experience in Konar MF using in VST location. May I request you to deliver your talk and then share your experience. I welcome you.
Thank you, Nagesh. I'm going to share my screen. Wait. Can you see my slide now, Nagesh?
Yes.
Okay. Good morning, afternoon, and evening to everyone. I'm going to share some interesting cases using Konar MF occluder. Yep. So I have no disclosure, and we do know that Dr. Nagesh actually implanted the first case in 2013, and the first case was done in the end of 2016. And at that time, we are actually very grateful to have this device in, but actually that time when we had this device, we actually don't know that it is invented by you, Nagesh. I'm so sorry. If you know that, we will probably ask you to come and demo for us. So I just want to share a little bit of Malaysian experience. This is actually collected by Dr. Martin Wong. We actually collected from 4 hospitals. We have 74 patients done using MFO or transcatheter VSD closure, not including of any other place of PDA or other place of apart from VSD. 74 patients, mean age of 14.1 years, median age is 43.3, smallest is 10 kilo. With 2 patients with underlying Down syndrome, retrograde approach in 23, median fluoroscopy time. Radityo, we still do under full fluoroscopy, 12.6 minutes. And the device implanted, our favorite is still H6 device. And I find that we are actually generally less used in those odd numbers. Maybe because we are so used to all these ADO device in even numbers. And actually 1 patient needed 2 devices. So 2 procedural failure, because probably 2 last the VSD, success rate is 97.3. With residual shunt in 9 cases, just very trivial and small, and our mean duration of follow-up is 8.2 months. And there's no complete heart block at all in all cases, with some mild AR and TR, very mild only all. But interestingly, we have 3 cases of RVOT obstruction. Nagesh, I've told you before that 1 patient just last month has surgically explanted this device. We do find that maybe the disc in RVDs is slightly bigger, but then again, maybe in certain patients with pre-existing mild RVOT obstruction, or whether aneurysmal tissue that's actually directed to the RVOT, probably not suitable to use this device. Okay, I have 3 cases, but maybe I just share 2 cases in the interest of time. The first patient is MF, 7 months old baby boy, term 2.7 kilo, referred to us for ASD and VSD in failure with history of multiple admission for pneumonia and heart failure. Weight at 7 months of age is 4.4 kilo, vital sign was stable, patient was tachypneic with hyperinflated chest, liver was 3 centimeter, X-ray show a cardiomegaly with a rhetoric lung field, and echo actually shows a kind of a moderate 5 millimeter ASD and an apical VSD, or maybe kind of a mild switchy appearance on the apical and a mid-muscular VSD. So you look at short axis view. So looking at this echo and clinical presentation, also with underlying pulmonary hypertension as all. So what are the treatment options that will you consider? One is 7 months, 4.4 kilo EA banding, or two, maybe surgical ASD and VSD closure. It might be difficult for the surgeons to actually close the apical VSD. Three, transcatheter ASD or VSD closure. Maybe Verario will probably approach this in a very small baby, or maybe hybrid per ventricular closure. Perhaps maybe I ask Nagesh, what would your option in your institution for this baby?
I think I agree with you. Either hybrid procedure or surgical ASD VSD closure, we are going to do it. PA banding is somewhat reluctant from my surgical side.
I see. Yeah. So I think we actually, after discuss with the surgeon, we decided for a hybrid closure. So we, of course, we target the apical VSD one first. The apical VSD measure about 4.1 millimeter here, and maybe another measurement 4.5 millimeter. We cross it with the wire. You can see the wire in the LV side, and put in a 6 French sheet. The reason being that I know we probably have to target the other, so we put in a 6 French sheet with the surgeon puncture the RV free wall for us with a perf string suture. And we have decided to use the MFO 97 in this case in the apical VSD. And the device actually was sitting very nicely after placement. This is the device, 97 MFO. And of course, there's also a mid-muscular VSD slightly higher up. We measure about 9.2 millimeter. So this one, we use the same sheet and cross it over again. And we use amplexer muscular VSD occluded 10 millimeter. Although I think it's still, if you use the MFO, it's still feasible, but probably it's best to use muscular VSD in this position. And not the ASD measure about 6 mm, 6.6 mm in 30 degree and 8 mm in 60 degree. So we decided, since we are there, we might as well close it as well using the same 6 French sheet. We close it with the amplexer septal occluder 10 millimeter. So this is the post per ventricular closure. This is the MFO, muscular VSD, and ASD in one patient with a per ventricular closure. So post follow-up echo show a good device position, and in the you can see a hint of a residual tiny VSD in the apical region. And in the short axis view, you can see the device sitting very nicely. And this patient was discharged post-op day 23, and last follow-up show a residual apical VSD, which is a tiny bit, and on annual follow-up. So I do find that apical VSD for MFO is actually a very nice device to sit in. If you put any muscular device, might not sit that well. And RV disc is actually a kind of a very soft device, and it can conform nicely with a lot of trabeculation and moderator band there. So I find that the MFO device sit very nicely. So far I've done 2 apical VSD by per ventricular closure, and the device is perfect for apical VSD. So let's move on to case number 2. This is AH baby boy delivered by emergency LSCS for poor progress with a birth weight of 2.2 kilo. This patient intubated at day 8 of life with respiratory distress and tachyarrhythmia. So this patient actually has a visible epigastric pulsation, and clinically also a pan-systolic murmur 2/6. Is there anyone in the audience who would like to kind of getting this diagnosis? Maybe you can put in the check box.
Yeah, it is looking like umbilical AVM.
Okay, umbilical AVM, like your case, like yeah. So probably it's not, Nagesh. This patient echo actually showed URV with the left sub-aortic ASD and small circumference ASD. So let's look at the echo first when we get back to the diagnosis. This is a large sub-aortic VSD, and this is a aorta. And then we go anteriorly, this is a pulmonary artery. And this is a long axis view. We show the atrial mitral discontinuity. and the VSD is there. And in a short axis view, probably can see a coronal septum here and some flow acceleration across the pulmonary valve. And ultrasound and abdomen and CT can actually show a pentalogy of Cantrell, which the LV apical diverticulum continues as a Blyden at artery. And with mild ectopic cordis with lower sternal defect as anterior diaphragmatic defect as well. As you can see, the CT scan, this is a LV diverticulum and kind of like form a long vessel into a blinded end. So treatment option could be whether actually I talked to my surgeon. This is not from my center, in another center, whether we should go straight for intraventricular repair, SD closure, and LV diverticular ligation. We probably will thoraco-abdominal repair as well. So this is probably a first consideration we are thinking. Or two, maybe this baby is still small, whether we have PA bending and just a LV diverticulum ligation as an option. Of course, the third option would be LV diverticulum occlusion and PA bending. So the center in northern part of my center, this center discussed with the surgeon, they are not very keen to kind of ligate this diverticulum because they cannot handle that thorax lower abdominal defect. They're not very keen on that. So we actually flew over to that center and we did the LV diverticulum occlusion. So this is the LV angiogram. Then in the LV gram, you can see that this is LV apex there. There's a diverticulum. It will probably seen clearly in when you put in a 4 French sheet. And you look at this 4 French sheet going down here, and in the LV here, the dimension is 7 mm at this apex area, and only 2.7 mm in this sheet at the tip of the sheet there. So looking at this, you have 4 French, you can probably occlude it in many devices like vascular plug 1, 2, and 4, or maybe a ADO2, ADO2AS also can fit in nicely. But then again, if you're going to target this thing, there will be a dead space here if you're going to target the vessel itself, or you probably can put the coil as well. So I want to put something that can occlude the LV apex area so that there's a very little dead space that will have risk of thrombosis in future. So a ADO device will fit, but then again, you cannot put it the other way around. That's where MFO comes in perfectly. So I chose a 6-4 MFO. I'm sure that the device is very soft, so I'm not very concerned about the RVDs. You can see, Nagesh, you have not seen your device in a mini umbrella kind of a shape. There you can see that this part is actually very small and a mini umbrella kind of shape here in your device. So you see the angiogram LV from the sheet size looks perfectly in a good position, and we release this device. So overall, this is the initial presentation. This is pre-procedure. You can see the pulsation and through this vessel, and immediate post-procedure, this thing kind of like silent. The pulsation. So this patient had a PA bending performed 9 days after the occlusion, but subsequently referred to our center for a complete repair. However, this patient immediate post-operatively developed a severe pulmonary hemorrhage and succumbed immediate post-operatively, unfortunately. So I just have one slide on Pentalogy of Cantrell. This first actually described in 1958 by James R. Cantrell. Is a collection of midline abdominal wall defect, which usually like omphalocele, and lower sternal defect, anterior diaphragm, diaphragmatic pericardium, and some form of intracardiac defect, most commonly VSD and tetralogy of Fallot. And also in India, you have a case very similar diverticulum and also DORV sub VSD. So that patient actually went on for LV diverticulum ligation first, followed by surgical repair later. So in published last year in Annals of Surgery. And incident is 1 in 65,000 to 200,000 live births with a male predominance of 1 to 3.5 to 1. And in those associated with congenital LV diverticulum is usually associated with arrhythmias, thromboembolism, infection, and rupture. So we need to tackle this LV diverticulum much earlier. So with that, I think I will probably skip the third slide, third case, and maybe we end this presentation.
Maybe you can just show last result. Yeah.
Yeah. So I think I would like to acknowledge the team in Sedang, that this is my whole team in Sedang and my 2 cardiothoracic surgeons, and also this Penang team. The second case is from Penang and Dr. Tamim and the team, and of course Dr. Martin Wong is actually the one collecting the MFO for the whole country. With that, I thank you for your kind attention.
Thank you very much, Ghee. There's a really fantastic cases. Actually, there are a lot of questions, but with the interest of time, there is a question and answer session. We can have more questions there if you want. Yeah. We can have there. And actually, it is my honor to introduce some of the people whom I know. One is Dr. Sebastian from France. He is from Maryland Hospital, Paris. Second, Dr. Adams from Warsaw, Poland. Third, Dr. Tomato from Japan. These are all very senior. And can you please unmute their mics and then give video also if possible. If there are any questions, I may request Dr. Mario Koneti or Worakan, other panelists to ask him. Otherwise, we will move on to the next talk. Worakan, can we go on to the next talk and then we will subsequently can have?
Yeah, I think we should go on to the next talk.
I think I would prefer to go to the next talk. It is my great honor to introduce Dr. Daniel McLennan. He is actually first person in North America to do a complex post-operative residual VST in a critical child who was on ventilator last week. It is my great honor to introduce you. Is from the Iowa University, very aggressive interventional cardiologist. I request you to share your case, and then probably it's a good idea to take some more questions, and then Worakan will interact after that. Thank you. I welcome you.
Thank you, guys. Can you guys see my screen?
Yeah, it's a very good, very clear.
Okay, perfect. Let me just go to the... All right. So thank you, everyone, and thank you for the introduction. And there's been some really great presentations. So I'm glad that I could be part of this conference. And unlike everybody else, I've only been using this device for a week. So this is our first case and the first one in North America. So I'll go through the case and give you some of the things that I felt were good about this device and how it helped me in this situation. So our patient was a 4-year-old female who weighed 15 kilograms, and she had a background of a complete AV canal and trisomy 21. So when she was 8 months old, she had repair. And post that repair, she was left with what was felt to be a residual VSD, plus severe left AV valve regurgitation and moderate right AV valve regurgitation. And she'd been relatively symptomatic, since that point of time. And as she's gotten older and more energetic, she's been having more exercise intolerance and increasing work of breathing. So she was referred to me for diagnostic evaluation to see whether she had pulmonary hypertension and whether she would be fine to go ahead with surgical repair of her valve. And so this was the echo that I initially looked at before I had done the catheter. And as you can see, there looks like there's a residual defect there in what you would consider the sort of perimembranous position, but obviously this is a AV canal that's been repaired. And so you can see as well how bad that left AV valve is and how much regurgitation there is, and also the right there with its moderate regurgitation in separate jets. And again, from this angle, you can see here more of that right AV valve regurgitation. And then on the short axis there, you can see that residual defect, how it's coming through and projecting off that right AV valve and causing some more right AV valve regurgitation. So I took her to the cath lab, and this was my initial assessment, that her QPQS was around 1.7 to 1, and this is under anesthesia. And as we all know, that's usually an underestimate. her PA pressures were actually quite good, and I thought, well, this child's still quite small. She's only 15 kilos. I wonder whether closing her VSDs would actually, improve her symptoms, and then maybe we could delay her valve repair. So I was lucky enough to go to Malaysia and got to see Dr. Ko do an MFO case, and I thought this device would be perfect for this child's defects. And so I say defects because at that actual procedure, when I did an angio, I saw there were actually 2 residual VSDs. There was one in a sort of a mid-muscular position. So I reached out to the Lifetech team, and last week on May 1st, we managed to get this child in and get the device. The device arrived at 2 a.m. and we started the case at 8 a.m. So we were very lucky. We were cutting it short. But you can see here where that defect is coming right underneath the sort of the first defect that we were looking at was a really posterior defect. So you can see there where the back groove of the right AV valve is, and then the other defect was more anterior and superior. So we took some nice pictures with the TEE and worked out what we needed to do, and then we took our angiogram. And so you can see here on the angiogram, there's that defect that's high up in the, as I said, what you would call sort of a perimembranous defect, and then there's a muscular defect that's lower down towards the mid-muscular sort of region. And so after watching Dr. Go do his case, I realized one of the great things about this is you don't have to make a loop. So you can just push your wire out, into to the PA, or in our case, it went to the SVC. So we then used the Lifetech sheath. And one of the things I liked about this Lifetech sheath is that it's really quite flexible. And as long as you don't have too acute an angle, you really shouldn't get a kink. And so it doesn't put much stress on the different structures. So we put out our right ventricular disc and pulled that onto the septum whilst looking at our TE to make sure that the regurgitation of that right AV valve wasn't getting any worse. So if I go back, I can try and I might have to click on this picture to show you. But just here, you can see how our disc was sitting in that right ventricle below the right AV valve. So we were able to pull that back, and then we deployed the left ventricular side, and you can see this is a 6-4 device. We measured the defect at 5 millimeters, and even then there's still some constriction on that left ventricular side. So the other thing with this device, and it's been pointed out before, it's so flexible that you look like you're pulling this device right up into the outflow tract. But when you know how this device behaves, that's going to drop down, so you don't have to worry about it sitting up like that. So we thought we were in a good position here, so we decided to release the device, and you can see over here in this picture, we were taking an angiogram just to show that we were happy that disc was conforming nicely with the left ventricular side. And so we released this device, and again, I'll show you here on that release on the picture on the right of screen how it drops down as soon as you release the device. And so we felt we had a really nice result from our first device. You can see a tiny bit of constriction on that the disc on the left ventricular side, and the discs conform nicely with the septum there. The other thing to note is just how much the device moves between diastole and systole. And I think that's a great thing with this device, that it's so flexible that it will move with the heart rather than trying to tell the heart to not expand as much because it's a stiff device. It's not. It's flexible. Now, the other thing you can see now with this second device is that actually second defect, there's probably 2 actual residual channels that go through to that right side. And you can see that the channel goes up and around. I'll try and pause that to give you a bit of a look at how that, so you can see here it does this kind of loop up and around, and there's something else going underneath, and that's obviously residual patch defect. So we did a sort of a bit of a novel technique where we used our pigtail, our 5 French pigtail, to push our BMW wire up into the aorta, drop it down and into the defect. And so you'll see here it just flicks below the valve and then goes up through the defect, and we made a loop into the PA. Now, because of the angle that we were at, we realized that we weren't going to get any sheath to go across that sort of loop. So we snared it into the PA and then pulled it down and made a rail. But again, because of what I had heard from people's experience with tricuspid regurgitation, or in this case right AV valve regurgitation, we still decided to go from the aortic approach and deploy that right disc first, and then pull it, across into the defect. And so you can see on the right screen there, we've got our right disc out, nicely through the defect, and that left disc out. Now again, you could be worried here that that disc is sitting up into the outflow tract, and maybe it could cause some obstruction. But if you remember the original angiogram I showed, the angle's actually angling down towards the apex. So I was quite happy that if I released this, the disc would drop right down and come right out of the outflow tract. And so you can see on the echo down on the left how we've got our two devices in place. And if you look on the top right here, you'll see that as we release the device, we just catch the top of the disc with the cable. So I actually had to pull back on the cable a little bit as it had caught the disc, just because of how tight an angle I was at. But then once the disc releases from the cable, it drops down quite nicely, and sits flush with the septum there. And so on our post look here, we couldn't get any angiograms post, just because the angle that device was at, I was worried if I tried to push a pigtail through there, I'd take it out. So I decided just to leave it. But again, just want to highlight here how that device will just open and close nicely with systole and diastole, and is not putting any pressure on the myocardium. And I think this is why this device hasn't had any heart block or any causes with rhythm at this stage, because it's just really good at conforming with the heart rather than pushing any pressure onto it. So, and the next day we did our transthoracic, and there's a tiny residual flow in the top right, but I was thinking that might have been that second channel that we saw on the initial echo. And then for our muscular one, you can see there's no residual flow there. So, good result for this child. She went home the next day, and she's doing great. So this was the team that I had, and like any lab, and I'm sure everyone would agree, you're only as good as the team members you have. And I had a very supportive crew who were all open to try this on this child. And, I had my partner, who's the tall guy in the back right there, Osama Aldous. He was really great at supporting through the case. So I think I have to thank them and Osama, but also have to thank Steve Pimento. He's been really great at helping set up the trip to Malaysia and getting me the device. Jen Maldonado, she's our research coordinator, but she was up all week trying to get this device to us. And of course, Dr. Ko and Dr. Mazni in Malaysia for showing me how the device works, and obviously everybody in the panel for their experience. So thank you.
Thank you very much. It's a great case indeed, because you have a post-operative complication and successfully managed with using 2 MFO, and that too retrograde technique in a small baby. Really, I appreciate. I think Dr. Mario Calmetti is waiting for the expert comment.
Oh, that's very interesting. Very, very, very interesting. And again, that's a very nice example about the flexibility of this device. How can you use it? Yeah, very, very interesting. It's likely that we can expand the indication of using this device in many different tricky situations. Very interesting case. Thank you.
Yeah, thank you, Mario. Yeah, I agree. I think this device has a lot of utility in a lot of the defects that we see. I mean, obviously, some of the presentations have shown how you can use it in any type of shunting lesion, but I think especially here in the US, where the Amplatzer perimembranous VSD device was first deployed, there are people here in the US who will tell you it's criminal to close a perimembranous defect because of their heart block. And so having a device like this that's going to change that game, I think will really allow us to close a lot more defects in a safer way. So, and its flexibility is just phenomenal. So,
yeah.
We will take one comment from any of the panelists, or Dr. Sebastian also is there. I can see him. Welcome, Sebastian. How are you from Paris?
Yeah, we're quite fine in Paris, despite all the problems with the virus. Thank you very much for this session. I had very much pleasure to see all the cases presented by the panelists, and I'm sure the MFO occluder will spread also in France, because I think, as it has been said, it is a very interesting device with its flexibility and the possibility to put it from both sides. Thank you very much for the introduction.
Thank you very much. Now I think it is my great honor to introduce my friend, colleague, and we work very closely, Dr. Worakan from Thailand. Worakan, it's your turn to present your experience
Yeah.
of Konar MFO, and then probably I request you to take the session and we'll moderate together question and answer.
Okay.
Welcome.
All right.
Yeah.
Thanks, Nagewara. Okay. So this is what I would like to do. Okay. Wait for a sec. Right. So again, my pleasure and honor to be here. You know, it's now almost 10 o'clock in Bangkok, so I'm a bit sleepy, to be honest. But yes, save the best for last and hope you can enjoy my talk. So, so my talk is actually about what's the next frontier company and also from publications that these data has been published. The total number is almost about 100 and about 40 cases. Just to share with you that the median age is ranging from 3 to 4 years up to like 13 years old. The size is ranging also from about 2 millimeter up to either almost 10 or 12 millimeters there. Approach some publication, they use retrograde approach 100%. But some, as Mario mentioned, that we can use either retrograde or antegrade approach, and it's about 40% of a 50-50 actually, retrograde and antegrade. Success rate is very high, as you can see, reaching more than 95%. Mean follow-up, well, because it's just recently published, so the mean follow-up is just not that much. Hopefully, we can get more midterm and long-term follow-up longer than what we have now. Complete occlusion rate is very high, and as you can see, almost 90%, sorry, 95% here, 92% there, and this one is 84%. Well, in my experience, actually, it's almost 100% did a complete occlusion. With this embolization 2 cases, dislocation 1, LVBB 1, left fascicular block 1, complete heart block 1 case. I didn't have a chance to discuss with the author yet, but this is also interesting thing that we need to explore. New tricuspid regurgitation and neo-aortic regurgitation also an issue of this device, even if it's not very very common. So with that, just to emphasize that this is multi-purpose occluder, it's sleek design, agile property. It means that you can go either antegrade, retrograde, conform in different morphology very nicely, and it's reasonable initial and clinical data collection. And as you can see that at least VSD is one of the most common indication, fistula, PDA, and also like PVL, I mean for Rava leak or AV malformation or even MAPCURS, you can use this device too. Just to share with you that you know, this device is very nice, as we discussed previously. If you deal with something like a body defect or like LV to RA shunt with the VSD like this, and you can abolish the shunt very nicely using the retrograde approach. And again, just to share with you that once we have this problem, we normally try to go retrogradely, open the disc on the right side, pull it back, and see how does the TR look like. And you can see it's very nicely showing that TR disappear completely just immediate after release the device. But it's not all the cases. Well, this is the patient that have a muscular VSD, you know, for the top TOF. So our surgeon requested us to close muscular VSD before the patient went for complete repair. So, you know, it's here, the muscular VSD. And then when we try to deploy the device, this is a very peculiar course, but just to share with you, this is aorta coming back through the VSD, cross the through the aorta to the right ventricle, cross the VSD, and then get to the left ventricle. So what we did here, we try our best to push the disc, especially on the right side, in order to avoid tricuspid valve entanglement. But unfortunately, we really not be able to, you know, avoid the TR. And in this particular case, TR just is getting really worse. So eventually we decide to remove this device, and we just tell the surgeon that we cannot do that. And also, just to share with you, as all of the speakers just share, that this can be used very nicely for small children. And this is one example: 8 months old, 6 kilo, recurrent pneumonia, and that was our very first experience. I think that time that was almost 3 years back. So again, just to share with you, it's very nice example of the big device in small child with very good result. But it's not all the case. So this is one of the cases I would like to share with you. This is for some reason the patient post-coarctation repair, but the surgeon that time thought that VSD is not a problem, but eventually it was a problem, because eventually the patient cannot wean off the ventilator. So then we really need to help the babies out. As you can appreciate that this VSD is actually pointing towards the pulmonary valve. So it means that this is outlet VSD. I'm not sure that you can see it very clearly or not, but that's the VSD. It doesn't look that big, but it's big enough for the patient, for this patient to get a problem. So we decided to bring the patient into the cath lab. QPQS is not a big issue. Well, you know, at that time I thought whether or not we should do it, but you know, we're in the cath lab and we know exactly the patient cannot wean off ventilator. So we went ahead with the procedure. Initially, we started to use the MFO because we thought this should be good for the babies. And because the size of the defect was about 4 millimeter, so I decided to use the 7x5, the MFO. So deploy, as you can see, that eventually when we try to deploy the device like this, I mean, in antegrade fraction, it's not lucky for this patient because this device seems to be big enough in order to avoid the aortic valve to move nicely, and also the RVOT is completely obstructed with this device. So again, it's not all the cases can be done by the MFO. So it doesn't mean that you know, it's a bad one, but it means that at least we know there's some limitation on the Kona MF device. So eventually, this patient, we decided to use the ADO2AS 5x2. So 5 stands for the diameter of the waist of the body, and 2 stands for the length of this device. And eventually, we were lucky because we can finally you know, release the device with minimal residual leak, and also, as you can appreciate, there's a mild AR at the beginning. So so we discussed with the surgeon whether or not we should leave this device. They said, well, please go ahead because I won't go for surgery anyway. So so that was the after cable detached. So luckily that AR did not progress, and now we follow up this patient more than 2 years. AR did not progress. And this is a chest X-ray before and after the procedure. Right. So just to emphasize again, when we discuss about the MFO or the Kona MF, it means that this device is double disc design with the body in the middle like this, with the hub on both sides, and it means that we use this in very multi-purpose you know, indication. But again, we can you know, have some improvement or have some adaptation adjustment for this device. As we discussed previously, there's some we experienced the tricuspid valve issues. So if for some reason, if the company can think about reducing the size of the right ventricular disc or low pressure disc, that may reduce the TR risk when we use for the VSD. Or if we deal with a small child or you know, in a very limited space, so if we can have a device which is a bit shorter than 4 millimeter, about maybe 2 to 4 or 2 to 3, something like that, together with smaller of the disc on both sides, and then even if we can reduce the risk of the nearby structure injury of the hub by reduce the size of the hub, that would be the perfect device. And also, that's the thing, that the largest diameter now that we have was about 20 by 14. So if for some reason the company can have a chance to have a big device, I mean bigger device, and with that we can treat even more sizable or larger defect. But the thing that we need to be very, very concerned would be the device stability and also residual shunt. So what's the next frontier? I would say that the next frontier for this device is going to be the Kona MF family, in my opinion. The family means it doesn't have to be only one device, but it has to be a family that have some modification in order to adapt or adjust with the proper anatomy and morphology of the patient's problem. But even if we have very good family, we need also a good delivery system. So again, as you can appreciate here, that with the cable, which is quite sleek, but it's a bit rigid. So with that, sometimes it may cause a problem because we cannot deploy the device very nicely, and we not very exactly know that after we release the device, how does it behave. So if we can use the cable, which has more flexible enough, and that do not have much tension for the device, and then we can even have expanding more potential for this device for the small and very challenging anatomy. So in conclusion, ladies and gentlemen, I would like to say one device cannot fit all, but eventually in the future, hopefully, one family can fit most. And like similar to the COVID-19 problem, I think this is a problem we cannot solve by ourselves. Just one person cannot do it. But with a family like this, at least today, we join together, we discuss together, we share things together. That's one family that can fit most. Thank you very much indeed.
Thank you very much. It's a great talk and your experience and views very well appreciated by everybody. I would like to give a couple of comments and then I will ask the senior people here. I take your points of developing Konar MF modification too, but not for that. That we are already working on that and we had discussion. But pertaining to this device, the TR incidence is low, provided you have to meticulously do the procedure. If you are doing antigrade method, that means the first disc is a high pressure disc, that is LV disc, the second disc is low pressure disc, that is RV disc. You have to push the disc to approximate coaxial to the intraventricular septum. Whereas when you are doing from retrograde technique, the low pressure disc, that is RV disc, obviously, invariably pulled towards the intraventricular septum. That's why you will not develop a TR. I have seen so many cases like that. That is one comment I would like to give. And your point of a flexible cable is very well appreciated. And this device is very good for selected cases. Your second case is actually, it is a subpulmonic VST. It is subpulmonic VST. The disc probably could not align to the intraventricular septum. It was projecting and also it was touching to the aortic wall. So I am concerned with that case. Probably I will not select that case for the device. But it is, I mean, since we are very close, that's why we are discussing all this matter. I would like to listen comments from other panelists now.
I've got a quick comment. I think it's Worakan, great talk, and I think it's the right thing to always be thinking about in improving any device. Nothing's ever perfect, but sometimes there's also a risk of tinkering too much with something that already works well. One of the questions I have, I saw a few of the panelists in their presentation really sort of oversizing the device, and I'm just wondering, from you guys have had a lot more experience. Do you recommend that, or do you think you need to? I mean, I didn't really oversize the devices I used much at all because I felt that the benefit of having a right disc and a left disc, that them being bigger, that they're going to stop the device really embolizing, and the waist should just be enough to kind of block the defect without really having to try and expand and squish itself. Because I would feel, and I think Mario showed it in his talk, that if it's too big, it's going to squish out that way a little bit if you squish the middle part, because it's got that flexibility, and that might make things hang out more and maybe some of the obstruction of the LVOT, etc., would have been less if the device wasn't as big? Or did you think that you need that oversize to really get the stability that you need?
Yeah, thanks for this important question, actually. When we select the device, it's not just about the size, but it's also about the relationship between the device, the disc, and the aortic valve, tricuspid valve, whatsoever. We're talking about the VSD. So the case that we did, actually, that time we didn't have the 6x4, I think, so that's why we used 5x7. That's one of the reasons. And also, as you mentioned, that try not to oversize too much. But sometimes you never know. You never know means that because this is a soft device, so I'm not so much worried if I oversize it. As people mentioned that the risk of the heart block is not that big concern. But again, I take your point that try not to oversize too much. But again, not just all the cases we can do that. Nagewara, if you can share.
Yeah, I'm actually waiting Mario's comments, actually.
Yeah, please, Mario.
Yes, actually, I agree that there is no need to oversize too much the device. But I've been surprised that in some cases, particularly when the imperimemory VSD is with the very tiny aortic rim, let's say, I was surprised how the device was able to conform and not to impinge to the aortic leaflet, in spite of the fact that theoretically the left ventricular disc could have been very, very large and very close to the aorta. So I think, as Worakan mentioned, not every single defect can be perfectly closed by a single device. But I must admit that in my relatively small experience, this device has the most flexibility and conformability as compared to any device I ever used in my professional life. Actually.
I totally agree with this, Mario. Well, honestly, it's not because I'm not a big fan of this device. Well, to me, my experience is actually that is the most usable device to close VSD. If I can choose one of the device on my shelf, that would be the one that I'll use. But again, just to share, that is not really all the cases can be done, but just in particular case that we probably need to be a bit aware.
Yeah.
Just to, in my experience, just I do oversize in cases of VSD with RCC prolapse. I had one embolization. I used the 1 to 2 sizes higher of the defect, then it embolized. Then I did another size which is too much higher than the previous one, so it directly fits the VSD in case of RCC prolapse. But in other kind of VSD, usually size the occluder 1 millimeter higher than the VSD.
Dr. Jesus Demesti, would you like to give a comment? Can we unmute the microphone?
Actually, this MFO is a very forgiving device. Generally, sometimes the intended device I want to put in is not my shelf. Therefore, I actually got one size bigger and usually without any much problem. I think this is a very flexible and forgiving device and conform very nicely with your VSD. So, and also second comment is the Worakan suggestion is good. If a smaller RVD is probably the RVOT obstruction can also reduce apart from the tricuspid regurgitation problem. But then again, if you put the device length a bit too short, I'm actually worried about the clamping force and what happened with the amplexer membranous at 1.5 millimeter. The clamping force is too much, that will cause heart block. I think so far your device is a very forgiving and not causing much of a complete heart, no cases of complete heart block. But if you make it too short, I'm worried it might be induce certain patient with a complete heart block. That's just my comment. Thanks.
Yeah. Coordinator Satya, can you please unmute Adam? He is asking some question. Do you have control? Can you please unmute? Meanwhile, Jesus, can you please give your comment on Worakan's talk or whatever is available?
Hi guys, can you hear me?
Yeah,
Yes.
we can hear you.
Yeah, I had a question. It was not a question. It was really a comment about this oversizing. I think in muscular defects, the discs are sometimes quite far away from the septum, especially the right disc. Is somewhere between the trabeculations. So as a matter of fact, if you oversize, the device conforms nicely to the shape of the defect, which may be oval or irregular, and then this oversizing is really necessary. What do you think about it?
Worakan, would you like to answer that? In muscular PSTs, you can oversize. There is no problem if you oversize. And also, we measure the defect from the left ventricular side. It is mandatory to oversize 1 to 2 millimeters so that it will approximate. Otherwise, you will have conical shape and the high pressure left ventricular disc will be pulled or pushed by the LV pressure. We agree with your comments and accept that.
Yeah, Adam, in my feeling or experience, it depends on how the muscular VSD look like. If it's just one single muscular VSD, I think, and without the adjacent tissue, something like tricuspid valve also, you can oversize. But if you deal with the species VSD, especially on the apex, so with that, sometimes oversizing, it will be even more elongated the device, and it may cause a problem because the disc will not fully conform to the anatomy. You may try, to oversize and see how does it look. But again, depends case by case, to my feeling.
Yeah.
This. Well, when putting a device like this with 2 discs and a central waist in the muscular septum, you may end up by leaving 1 disc only on one side and the central waist and the other disc on the other side. Or if you pull, implanting from the venous side, a bit more, you will end up with the central waist more engaged in the tissue of the ventricular septum. But this is an advantage, in my opinion, of this device, because according to the different morphology of each individual patient, you may adapt the position of the device more engaged in the ventricular muscle or less. Depends upon any individual morphology of the defect. I'm not sure if I explained exactly what I mean.
I'm convinced with your explanation, and it's a good idea not to pull too much. Let it confined and then leave the disc, because it has got a property that the disc can be elongated and approximate that.
Yeah, and exactly. If you use an oversized device and you engage too much in the septum, you're likely to end up with a very elongated device.
Yeah,
that's the.
Jesus, would you like to give a comment? We are sorry that we did not ask you.
Yes, 2 or 3 comments. I never seen a Pac-Man effect with this device. That I saw with the muscular VSD of another devices, right? So the second, I tried to close a fistula, a coronary artery fistula, and it was impossible to reach the right coronary artery because the length of the sheath was not so long, yes, and it was impossible to reach the coronary artery. And I asked the company to have a longer sheath, because sometimes the fistula is necessary to close by retrograde approach instead of anterograde approach, right? And they told me that it's not so easy to have this sheath. And the other aspect that I asked the company is to have a smaller right disc, smaller hub, and smaller disc to treat vessels with smaller diameters, right?
It is true that we are coming up by 2021 ending or middle of 22 with MFO 2, which is going to cater for variety of other indications, especially in the smaller babies and other peripheral cases. So that we are working on that. It's a great ideas from everybody. Maybe Worakan, can you please lead this session from here?
Yeah, thank you. Just because I heard, I saw Adam would like to unmute. Staya, just one last question from Adam or comments. I'm not sure if you can unmute Dr. Adam Kolesnik.
Thank you so much. I just wanted to continue a little bit, because our experience is that we usually cross the muscular VSDs, especially those apical ones, from the right ventricular side, and we are closing them to without the loop. So basically, the technique is to pull the LV disc first, and then to fill the defect with this middle part, which resembles like this part of the Angio, right? And then the right ventricular disc sometimes is somewhere between the trabeculations. So that's why I commented on that we usually oversize by 2 millimeters just to be firmly conformed.
Thank you. Thanks, Adam. So any more discussion or comments? Right. So once again, this is, I'm overwhelmed, you know, with the mentoring things, expert opinions, and also having discussion with friends and colleagues and people around the globe. So as Dr. Ko mentioned, that good afternoon, good morning, good evening, whatsoever. So we have participants here. The maximum was about more than 400 people participation. So you know, that's my great experience of having this. And once again, I'd like to thank you know, my moderator, my inventor, Dr. Nagewara Koneti, that you know, run the session together with me. Also thank all the speakers, Dr. Mario, Dr. Jesus Damsky, Daniel from the US, Dr. Radityo, Dr. Valerio, and also Dr. Ko from Malaysia. So again, that's a great session that we had. And last but not least, we would like to thank the Lifetech company. Oh, Richard is here. Do you want to say something, Richard?
Hi, Dr. Worakan.
Hi. Because
so
well, we probably gonna end the session, but thanks for you know, supporting this kind of meeting. I think this is very wonderful idea of how we're gonna join people together during COVID time. So if you can say something.
we really appreciate this scientific educational webinar. We hope we can be your partner for the future, all the education and scientific programs. Myself and my team learned a lot from this. Thank you so much to you and all the professors and doctors.
So, so on behalf of me and you know, Dr. Nagewara, so we probably would like to again thanks for everything and hope we can meet up again. So there's some comments from the audience of the participant that next time we can have some case discussion like Life in the Box. So hopefully we can do that next time. So Nagewara, you can say something.
No, I would like to thank and congratulate the Lifetech team, especially James from Lifetech, who is coordinating, and Richard, a global coordinator, and also North American team, Mr. Satya Gusri. All these people, they put their efforts to make this meeting a very great success. And we have 420 participants here, and people from Malaysia, people from Indonesia, Philippines, Argentina, and especially seniors like Mario, who took his time and then actually participated and gave his expert comments. So that's all I can say. And be safe during this COVID period.
Oh, thank you very much. Let me add a few words to Nagesha, to Worakan, all the friends, speakers, and the Lifetech company for putting up this program that was, I think, very, very successful. I mean, I'm sure that all people attended this session learned a lot. I certainly did. So I think this experience deserves to be replicated in future, for sure. Thank you very much to all. Thank you.
With this, maybe I would like to close the session, and then hopefully that we can meet up again next time. And stay safe, please, all of us.
Thank you.
Thank you. Oh, last but not least, thanks Taya also. He's moderating all the session very nicely.
Thanks so much. Can I end the meeting, sir?
Please.
Thank you.
Good night. Good morning. Good afternoon.
Bye-bye.